Thanks everybody for coming. My name is Roberta Vastano and I'm an assistant scientist in Dr. Eva with the Storm Dongas Lab. So today I will introduce you to my research. The focus of my research is trying to understand the cortical mechanisms following spinal cord injury. In particular, a focus on multisensory perception and body representation. I have an interest using EEG mechanisms as well as modeling, mathematical modeling of behavior. The main focus of my research is to understand not only how this change following spinal cord injury, but also what's the relationship with neuropathic pain, because up to 80% of these individuals suffer from neuropathic pain. And also what can we do to develop non-invasive approaches to improve pain outcomes. Now, today I will not focus on everything of this, only particularly on the multisensory perception, and I will also introduce you to new ideas, new studies that we would like to do. So before to start with my research, I just want to give you as a short overview how cognitive mechanisms change post-injury, because we may think that with spinal cord injury, there may not be cognitive deficits, but that's actually wrong. It is an understudied dimension of spinal cord injury, and it is very important. Most of these individuals, they face comorbid condition. So they have anxiety, depression, in particular, this type of comorbid condition are related to neuropathic pain. These are very common and they are linked to cognitive impairments and reduced quality of life. They also face a high substance abuse. Most often, we have an undiagnosed TBI following spinal cord injury. Most likely individual with very high injury, cervical high injury, they may have TBI. This may worsen cognitive dysfunction as well. Neuropathic pain is known to affect memory, attention, focus, influences also overall cognitive performance. There is also the side effect of long-term use of medication that can impact cognitive functions. And the emerging use of invasive intervention like DBS may have effects on executive function. This is more known in Parkinson's. There have been studies showing that the DBS may induce some decrease in executive functions. It is not very clear yet in spinal cord injury, as well as how this can impact the sense of agency, which is motor control and self-awareness. And we know that we also see a widespread neuroinflammation. So neural loss, neurodegeneration, they will have an impact on cognitive mechanisms. So now try to guess what's the percentage of individuals that do have a cognitive deficit following spinal cord injury. It is quite high. It's between 40 to 60% of individuals that develop cognitive deficits. Most common, they have poor attention or disturbed memory learning, visual perception and pattern recognition. And this is very important because even if I do not, my research particularly don't focus on visual perception, but I do EEG, every time I look at visual potential, they are very much reduced in spinal cord injury. They have decreased problem-solving ability, a decreased processing speed, as well as deficits in fluid intelligence. So with this, we know that anatomical and functional changes happen to the brain following spinal cord injury. What is well established is that following spinal cord injury, we know that there is many studies that have looked at cortical level for somatosensory and motor functions. So many studies are, they're well known that there is change in somatosensory processing and motor, even using EEG fMRI. However, in following spinal cord injury, this type of techniques like EEG fMRI to understand cognition are still not much used. So cognitive changes post-SCI still remain less understood. If we do not use this type of techniques, it's hard to understand what's happening to their brain. So I just want to show you a few studies that focus particularly in EEG because I work with that. For example, this study had 18 individuals with spinal cord injuries and eye control to perform a cognitive task called go-no-go. I don't know, is anyone familiar with the go-no-go task? Probably no. It is a task that studies proactive control. So these little squares are basically the screen in front of the computer. So the participant is looking at the fixation point in the middle of the screen for about 1,000 to 2,000 milliseconds. And then after this is going to be presented for a very short period of time, only 250 milliseconds, with the target stimuli. What does it mean? They are instructed to respond to this target stimuli. Every time they see this pattern or this pattern, they have to press, for example, a space bar. Alternatively, they may also be presented with non-target stimuli. So when they see this type of stimuli, they do not have to respond. They have to inhibit the response. And this is hard to do because this is very fast. After 2,000 milliseconds, you see this very fast and then go on all the time. So even control subjects make a lot of error rates, and that's very normal. What they have seen, the following spinal cord injury, two components known as prefrontal negativity and readiness potential. Each of these components signify different dimension of the processing of this stimuli. So the prefrontal negativity is a negativity that arises at prefrontal sides, mainly when we have to inhibit a response. So it's higher when we are able to inhibit a response. Control subjects seem to have an intact prefrontal negativity, while spinal cord injury individuals, regardless of the time post-injury, they do have a reduced negativity. As well as for the readiness potentials, it's a potential investigated that usually peaks on central parietal side and is more negative before the response is made. So it's a motor preparation potential. And we can see that it's higher the motor preparation in controls than following SCI. Most of these individuals, they were thoracic to lumbar. Yeah, but they only had to press a space bar. So it is not as much. So you may expect that there may be differences in the reaction time, how fast they are, and there will be. That's for sure. There will be. I'm sure they found that I don't have the behavioral results, but this is at the brain level before a response is made. Yeah. Yes, it doesn't matter of this is before, yes, at 0, here you have a presentation of the stimulus, so the response is around, this is the reaction time of them, so it's around 600 milliseconds. So here, even if there is motor variability, they are looking at what the brain is doing when these stimuli appear. That they know they have to go or they know that they have not to go. So they have to proactively select the motor response to perform the task, to press the bar or to not press the bar, to basically inhibit the response or to perform the response. I guess they're probably correlated with, as you say, the motor deficits or level of injury. I don't recall if they have done any check on this, but this is before the response is done anyway. Another example, this is a very simple task. So participants are exposed to stimuli that are only auditory. They actually in this task don't have to do anything, they just have to listen. So they listen a series of stimuli. This can be standard stimuli, like the white bar, which are auditory stimuli of 1,000 Hertz. So they may feel like beep. And then occasionally they are presented with the deviant stimulus, which is around 500 milliseconds. So they are listening to this series of stimuli, auditory stimuli, which are like beep, beep, boop. So when they hear the boop, the brain reacts to what is unexpected stimulus. And what they found is that spinal cord injury have a reduced P300 negativity over posterior parietal and centroparietal side. So P300, the black line is SCI. The P300 negativity is a potential that is known to be present when we are processing sensory information that is unexpected, like in this case. This is a better visualization of the data, reduced P300 amplitude in individuals with SCI. They have a much larger population, 37, and the level of injury is from cervical to lumbar, so it's more heterogeneous as well. Our lab also has shown that visospatial processing is impaired. In this case, participants are exposed to body-related stimuli or non-body-related stimulus as a control. So this is the screen. Participants sit in front of the screen for about 1,000 milliseconds. They see a fixation cross. Then a stimulus that can be body-related or non-body-related is presented. The task in this case is to perform a laterality judgment task. They have to indicate verbally if what they see is a left or right stimulus. In order to do that, you need to internally simulate a motor response. We do have two types of conditions, have easy condition with the rotation angle of 75 degrees. So this is higher for you to identify as a left foot. And the harder condition, 150 degrees, this is harder for you to identify as a left foot because it's a much harder rotation to perform. We do find the spinal cord injury have reduced amplitude for the Pareto P100. And what was interesting is that for body-related stimuli, in particular the feet, they have a reduced amplitude also for the rotation-related negativity and no specificity for the rotational angle. What does it mean? This negativity arises at posterior sides and is a potential that is more negative for harder mental rotation. So in this case, the black line is healthy individuals with performing a mental rotation of the feet 150 degrees. They do have a higher negativity compared to the 75 degree. SCI do not have this difference and they have a much lower negativity, meaning that both rotation for them is harder to perform. What is interesting in a follow-up study, we also found that spinal cord injury individuals with cervical injury have much lower potentials than the thoracic injury. So this, the level of injury has an impact on this type of task performance. Interesting, we found a body-related modulation, basically for the harder rotation angle, so the harder condition, individuals they have cervical injury have reduced P100 amplitude only compared to the thoracic group, only for those stimuli that are body-related and not for non-body-related. Overall, we also find a larger, longer latency for the cervical group, but this was more or less expected because the injury is more severe. So this is just to show you that at the brain level there is changes in visospatial processing, cognitive control, and simple auditory processing of information processing. So, yeah. Well, in this case, because what they do is a body-related task, so I would suspect if that's true, they've been related also for the non-body-related stimulus. So that would be overall harder to make that type of task. We do find the specificity for body-related. It is related also to the fact that their motor ability is more impaired. Yeah, we control for age, sex, we control for all of that. Yeah, we do. That's a good question. Maybe Gary may know better.
It's actually going to be part factor 1, so we'll let you know.
Are you looking at brain mechanism? Yeah. Okay. Yeah, that seems. They were both complete and incomplete. It's we didn't have. I think we checked in both studies. We checked for completeness. We do not find, but there is a study that has found a different complete injury more impaired. We were expecting that too. We didn't find it. So to perform this type of task, in this case, mental rotation of body part, we do need an intact body representation, which is a multidimensional construct almost like a picture of the body that we have in our brain. It depends on many factors. Depends on intact perception, intact body memory, proprioception, interoception, and vestibular input. Now, try to imagine that after SCI, perception is impaired, proprioception, vestibular inputs are impaired. So, besides the sensory and the motor impairment in this population, what is interesting is to see that most of these individuals also have abnormal perceptions of their body part. And this comes when they have severe pain. So lots of individuals feel burning type of pain, including their hands and feet, evoked pain, pressing, paroxysmal sensations. All of these feelings affect the way we perceive our body. And there is some evidence showing that when we have a painful body part, we perceive it as bigger. So it changes the representation of the body. And this is what we are trying to do with our new grant. So it's a DoD-funded grant. I will not show any results because this is an ongoing grant, but I will only show you with the aims of the study. So we first aim to investigate the cortical measure of body representation in the individual who have pain and no pain with spinal cord injury compared to control. And we are expecting that the task I just showed you before may be sensitive to the presence of pain or at least to pain severity. Then in aim 2, the participants, they have neuropathic pain, will undergo to a series of non-invasive intervention using transcranial dural current stimulation, position located on the posterior parietal cortex, which will be contralateral to the most painful site. Together with the stimulation for 30 minutes, they will undergo two types of bodily illusions, rubber hand illusions and walking illusions. So when we perform this type of illusion, we manipulate the multisensory stimulation in a way that we change briefly our body representation. You may have a feeling of embodiment or ownership over a fake body part. In this case, would be either the fake legs or the rubber hand. And then in aim 3, we qualitatively assess the effect of this type of series. How did they like it, if there is suggestion, because we also learn a lot from these individuals. And we also assess quantitatively the effect on a variety of pain symptoms and signs, emotional function, and pain interference. Some of them. Yeah, in these previous ones, we were not looking at pain. Some of them had the pain. We were not looking specifically to find difference between who have pain and no pain. We also have a very small population here, 40 individuals, here's 20 individuals. Now we are having a much larger sample size for these new studies. I believe we have 30 individuals in each group, so that way we can compare 30 individuals with pain versus no pain. So what we have learned so far. So SCI alters cognitive functions. Attention, memory, executive function often show measurable deficits. Body representation, which is how the brain maps and perceives the body, is also impaired, and the presence of pain may further alter these processes. So cognitive deficits in spinal cord injury reflect changes in how the brain processes, prioritizes, and responds to information. And this is involved because this is the main interest of my research. I want to understand how they process and respond to sensory information. How does that change following spinal cord injury? And this is the topic of my second part of the talk, which is multisensory integration. How does the brain adapt when its sensory inputs are altered? So in order to perceive and interact with the environment, we rely on cross-modal processing, which is the ability to integrate cross-modal information from touch, sight and auditory, taste, everything. So in order to have cross-modal process, in order to have multisensory integration or cross-modal processing, this type of behavior also depends on an intact motor system, because this is important and it is needed for control, for posture balance, and to guide the movement. So it is all interconnected. Cross-modal processing is interconnected with the motor function, intact motor functions. Following spinal cord injury, Altered perception can lead to impaired sensory integration because for sure we assist to deficit in somatosensory. We have reduced visual activity and higher instead auditory activity. And together with this sensory impairment, we also have motor impairments. So this type of imbalance in the sensory and motor processing will have an effect on the way they integrate and process that information. So before I present my study, just briefly introduce what is multisensory integration. It's the ability to create a unified percept by integrating multiple sensory input. So in this case, we are looking at neural response from a single neural recording from cats. As you can see, we have visual, auditory, audiovisual. So we have multisensory integration when the bimodal condition, in this case audiovisual, exceeds the sum of the unimodal responses. Only this is the multisensory integration. Without this type of response, we do not have integration. It is believed that it only happens if the two stimuli synchronize at the same moment or happen in the same receptive field. In the case of animal studies, in our case in humans, it also follows the temporal rule and the spatial rule. If they are not temporally synchronized, they need to appear in the same space. For us, for our brain to have an effect similar to this. Multisensory integration influences a variety of perception and behavior, from object identification, speech perception, temporal perception, coordinating perception and action, and also recognition and recall. It is studied so. Yeah, it's good. It's a superior colliculus of a cat. Yeah, of a cat, yes. Yeah. Yes. This type of neurons are abundant in the superior colliculus of the cat. Those are former works on multisensory integration. In humans, we do have multiple brain regions that respond to multisensory information. Particularly is the posterior parietal cortex. But there is also some subcortical or sensory-specific area of the brain that are able to respond to multisensory neurons, depending also on the modality. It is measured multisensory integration in a variety of methods. What we use in our lab is event-related potentials and also modeling, mathematical model of behavior. So when we started to study multisensory integration, we first published the review paper because we wanted to understand how multisensory integration would change following spinal cord injury. And we have different hypotheses. First of all, we believed that as an opposite factor of integration, we would find depression or competition effect in spinal cord injury because of all these reasons. We know that they have motor, proprioceptive, somatosensory impairment. They do have reduced experience with cross-motor cue. Think about complete injuries. So audiotactile or visotactile information is not the same anymore. There will be reduction in GABAergic inhibition, dysfunction, lateral inhibition. As I said, there is unisensory imbalance because vision and auditory information may dominate over somatosensory information. And there will be reduced responsiveness to cross-motor cues overall in multisensory areas or even in sensory-specific cortical areas. So this is a very simple schema of how integration may work following spinal cord injury. We believe that bottom-up inputs, somatosensory, will be weak compared to auditory, where may dominate. There is some evidence that, for example, auditory startle response are higher in spinal cord injury compared to control. And visual information may be, for example, intact. So this sensory imbalance will cause a deficit in integrating cross-modal information. In this model, top modal modulation were thought to be intact, but we have seen that there is, as I said, deficits in attention, proactive control. So this whole model, as in different points of the model, there is a deficit following spinal cord injury, from perception to integration to modulation to top-down activity. So because of this, we would expect a scenario like this. Instead of a superadditive response, as I just showed before, where the bimodal stimulation exceeded the sum of unimodal, we will see sided to subadditive effects, depression effects, or no integration. Subadditive meaning that there is some integration but does not exceed the sum of unimodal responses. Depression, it means it's almost the opposite, where the bimodal response is much weaker than the unimodal response, or there is no integration at all. Now try to guess which scenario we found came true. 1, 2, or 3. Well, we found evidence for subadditive. They do have some integration, it's just that the integration is much lesser than what is supposed to be. And I will show you now. We have recently done a study, EEG study. We have 37 participants with different type of injury, from cervical to thoracic, different type of also completeness of injury. 22 of these participants had neuropathic pain. And then we also test 22 controls. So in this task, they perform a very simple, what's called detection task. So they're sitting in front of a screen with the EEG cap on their head. They are required to looking at what's happening on the screen and to detect the sensory information. In this case, first they are presented with a fixation cross for 1,500 milliseconds. This is basically what they're looking on a screen. And it's only to tell them that something is going to happen after this. Then after a interval that was variated between 500 milliseconds to 1,000 milliseconds, there would be the stimulation. This could be either a visual green, visual green X in the middle of the screen, or an auditory information that we delivered via headphone, 1,000 hertz beep, or a tactile information, which was an electrical stimulus delivered on their chin. So everyone received a tactile stimulation above the level of injury. So these are unimodal conditions, and they lasted, each of those lasted 100 milliseconds. So they only could attend to one of these conditions in the unimodal conditions, or a combination of them, audiovisual, visotactile, or audiotactile. So only one of these would happen in each trial, okay? They were instructed to respond as fast as possible. We recorded both vocal reaction times and EEG. So what we found, so first, this is the audiotactile condition. On the top panel here, we have the behavioral response, and we have analyzed it in two ways. First, we standardized the reaction time and performed the RACE model, which is basically it's a model that tests for multisensory integration. It compares the sum of the bimodal responses to the sum of unimodal responses. As I said, if you exceed the sum, then you have integration. And this at 0, basically the difference between two cumulative distribution functions, above 0 you have integration effect. Below 0 there is no integration, which is most likely related to competition effect. This type of competition tends to increase with increasing reaction time. So we found that participants with spinal cord injury have much reduced integration compared to controls. When we analyze our reaction time, looking only at the 0.5% of the curve, so basically only where the reaction time were fast, or this little amount of reaction time, we still found the same effect. So these are reaction time divided by percentiles. We found that the 20, the 30, and the 40 percentiles, the reaction time was much lower than reaction time, integration effect was much lower than the ones that control presented. And this panel here are the event-related potentials for control spinal cord injury. And here we are seeing the audiotactile condition in blue, auditory in red, and the tactile in yellow. And you can see that controls have higher potential, in particular the P200, for audiotactile condition compared to the other two. And this is not happening in spinal cord injury. You can see here more clear the effect of the difference of the audiotactile condition between SCI and controls. Here in the panel C, we basically show exactly the same results that you see here, but at the topographical level. So at 200 milliseconds, what was happening in their brain? And you can see a higher positivity, a higher activity in controls for audiotactile compared to these two, and not much difference in between SCI individuals. We found the same results for visotactile condition. exactly the same. Spinal cord injury have reduced integration, as well as when we only look at the fastest percentage of the reaction time, the curve of the reaction time, they have high control subjects have higher visotactile integration compared to the visotactile processing alone. SCI do not show a similar pattern, and this is just a better visualization of the same condition, as well as the topographical map show the same result. And finally, you would expect that the visual condition would be intact, and we do not find that either. So we do find deficits also in the audiovisual condition regarding the mathematical model of behavior. When we look only at the fastest part of the reaction time, we do find an almost significant trend. At the brain level, we do find the differences. So the same pattern, controls have higher activity for audiovisual processing compared to unimodal. SCI do not show the same activity and is much more reduced. They do have an overall, compared to the two other conditions, an overall increase in the N200, but was overall, it was not specific to the multisensory stimulation. We believe it could be either that audiovisual information for them is more salient, so they were paying more attention to this type of stimuli, was easier for them to process. And this is the same pattern at the brain level, the same response with audiovisual information in controls having more a higher activity compared to visual and auditory. So finally, we performed also a new type of analysis. It's called the threshold-free cluster enhancement. This approach, while these ones we select which electrode we look from literature, or because we can basically already expect where an audiovisual information can happen, processing audiovisual information can happen in the brain, this type of analysis is data-driven. So basically, this threshold-free cluster enhancement consider how a single point relates to the surrounding and highlights areas of strong and spatially connected effect. What does it mean? That it does suppress those information that have low support from neighborhood and enhance those information even if they're weak because they have a strong neighborhood support. And we performed this on all time points in our EEG data. In our case, it was from minus 200 milliseconds to 500 milliseconds in all the electrodes. We used 30 channels electrodes. We performed each of these analyses for each residual effect, meaning that we basically compared the controls and the CI in residual effect of visotactile, audotactile, audiovisual. Basically, the difference of the bimodal minus the sum of unimodal. What we found that for each condition, different clusters of activity were significant. So here you see the statistic panel. So this is the time, and this is all the channels in the audiotactile residual effect. So the difference between bimodal minus the unimodal response. This comparison between the two groups, control and SCI. So first of all, we saw a stronger significance at the electrode P07, followed by C5, and finally from P3 electrodes. So they are all posterior and central electrodes at this specific time point. So very early in the time, participants that are healthy have a higher multisensory gain. We can call multisensory gain because it's a comparison of residual effect. So controls have a higher multisensory gain compared to participants with spinal cord injury very early in time, parietal, central, and centroparietal areas. When we look at the visotactile condition, we found a similar pattern, much stronger. We do have the same multisensory gain that happens very early in the time. So here we are basically looking at this. These maps represent, I forgot to say, represent the t-value, so that's the statistic. And then this first cluster then is followed by a second cluster between this time, so 100, 200 milliseconds about, and then is followed from a later cluster. So we believe that these two multisensory gain happen very early in the time, specifically for control subjects, and integration effects are higher in control subjects compared to control. The last cluster that's so late in time, we do not think is much more related to integration effect other than just information processing because it's too late in the time for a multisensory integration effect to happen. And finally, we also found audiovisual. For audiovisual, we do not find any integration effect very early in the time. We do find just a late cluster. So this analysis is very useful because it's data-driven. It's when you want to look overall the brain, what's happening. So what are the key findings of all this study? So we found a higher replay amplitude for multisensory versus unisensory stimuli, only in the control group. And the cluster-based analysis on the residual effect showed that the control group had a higher multisensory gain compared to SCI participants. So SCI has an effect, detrimental effect, not only on the motor system, but also on the ability to process multisensory information. Now, what about when sensory seeing as a rat rate on those individuals that do have high neuropathic pain and are presented with symptoms like capillary and allodynia? How do they process this multisensory information? So we performed also a pain assessment. We used the International Spinal Cord Injury Pain Basic Dataset in those individuals who have pain. This helps us to classify whether the pain is neuropathic or not, and to classify also the level, where it's present, at level or below level. Then we also perform a neuropathic pain symptom inventory, which gives us an outcome of pain symptoms, the neuropathic pain symptom severity. It allows us to differentiate between spontaneous pain, evoked pain, and paresthesia dissociation. The overall score of this test will give us what's called neuropathic pain symptoms inventory. It was neuropathic pain symptom severity score. So when we look at multisensory integration data in those individuals who have pain versus no pain, we do not find any difference. So the individuals that have pain are in purple, and individuals who have no pain are in blue. So the standard deviation is very high, as you can see. Probably with the higher sample size, we'll find something, but we're not sure, between pain and no pain. What we found that was interesting is the relationship with pain severity. We found that the higher is the pain, the better is the integration, actually. So as you can see here, this is higher neuropathic pain symptom inventory score. So the blue one have high, the purple one have high pain, and the green have low pain. In the audiovisual condition, they were almost significant. They do not, the integration effort do not correlate with the total NPS score, but what we found was that in the audiotactile and the visotactile conditions, we found, besides that the ones that have high pain integrates better than the ones that have low pain, we also find a positive correlation. So more is the higher the pain, the higher is the NPS, the higher is the integration process. And these are preliminary data that we are going to use for our future grant, trying to understand how pain severity is linked to multisensory integration. So participants with SCI with neuropathic pain show reduced multisensory integration overall. NPSS score positively correlated with the beta score of the multisensory integration outcome. So the higher the pain, the less negative is the beta score. There is a tendency towards a better integration process in those who have higher pain. It was some of them have evoked pain. Yeah, I mean, that's a good question. So when I looked at the subscales, actually the evoked pain was the one that did not correlate as much. The one that correlated most was the burning pain. Not much evoked pain. But overall, I used the overall score, but when I looked at the subscales, I remember the burning, not much evoked. I can look back, but that's a good question because that actually tells you about, evoked pain, more pain when you touch a surface, and so probably more or less integration. So the mechanisms behind this are several, so we are not able to distinguish between all of this is happening with this type of task like this, because abnormal sensory perception and so multisensory deficit can be related to a variety of consequences like disrupt ascending sensory pathways, release of inflammatory mediators, decreased inhibition and center sensitization, as a consequence, maladaptive plasticity specifically for somatosensory processing. So what we can conclude? SCI leads to cortical change in sensory information processing. This is more than only in the somatosensory domain. We hypothesize of a process of cross-sensory calibration or reweighting, meaning that they continuously calibrate the intact sense to interact the perceived environment, and they reweight basically the sensory input, because if the touch is impaired, they rely more on auditory and audiovisual or visual information. There is a need for more studies on cognitive changes post-SCI via neuroimagery techniques overall. So what will be the focus of future studies? So here now we introduce you briefly to what will be the new idea of my research. So first of all, we want to see whether the benefit of multisensory training may have any beneficial effect on pain. So basically, if you think embodiment of artificial device or long-term training sessions that are able to provide the multisensory stimulation, or to either modulate the multisensory integration and then to modulate also the body representation as an effect on the analgesic effect for pain. And also be able to develop strategies that can normalize the multisensory experience. This is possible if we do this type of trainings early in the injury time. We may have a better outcome because we may train them to keep processing some stimulation, some sensory information that are just happening to change, like in the acute phase. So the first future study that we hopefully will get to write, we just submitted a pre-proposal to the Patient-Centered Outcome Research Institute, is to study basically to compare the effectiveness of two types of intervention on pain. It's a parallel group randomized controlled trial. So we like to see whether exercise alone plus compared to exercise plus multisensory virtual reality has a beneficial effects on pain. We know that exercise alone does help neuropathic in pain, improves neuropathic pain symptoms. We don't know if a combination of these two types of intervention that if you use them in a single way, they do have benefit on pain. We hope that the combination of these may have more beneficial effects. So our aim are to compare the effectiveness of these two interventions, to also qualitatively assess the acceptability, the feasibility of this type of intervention. And we also will evaluate neural mechanisms and pair-related phenotypes to support treatment personalization, meaning that we will also have an EEG study where we look at multisensory integration in relation to pain severity. And this is just to show that this type of training are out there already. So this is an Italian group. This is called the multisensory climbing wall. It's a multisensory integration training developed for children with a motor disorder. So they may have stroke or they may have cerebral palsy. This is basically a consequence of decades of multisensory integration research. So now this is in a hospital, but basically it's a multisensory climbing wall, meaning that these children, they learn to climb in particularly using this type of devices that are able to provide visual information via LEDs, auditory information, as well as tactile information, and they also wear a smartwatch that is able to provide vibration. This is because multisensory integration enhances perception and action. So this is to see if they get faster at moving when they integrate sensory information, and they do, because that's the principle of multisensory integration. And again, there are also clinical trials that study the effects of basically virtual reality paired to a peripheral stimulation compared to virtual reality alone or only peripheral stimulation alone. So in this study, participants with the neuropathic pain they just wear goggles, and they, in this particular case, they see a wave approaching the body and leaving the body, and they try to stimulate at the same time the peripheral nerves, so synchronized with the visual input. So this is a visual tactile environment. They record pain, other outcome, as well as EEG. And they see that only the virtual reality plus the synchronized peripheral stimulation is able to reduce neuropathy and pain up to a week. Other outcomes that have improved also were tactile acuity, proprioceptive measure, and EEG biomarkers. Now, what is important, if you can see here, is that the improvement of pain was of 30%, which is of clinical relevance. Other future study will focus on mechanisms, so on plasticity, as well as it's important to select populations, so controlling for injury level, completeness, and time post-injury. So I recently submitted a LOI to Wings of Life under the topic of plasticity to understand whether pain severity and multisensory integration, whether pain severity can affect multisensory integration in two types of conditions, whether if the stimuli happen within the peripersonal space or outside the peripersonal space, extrapersonal space. So multisensory integration is well known to improve or to have a greater response when it's close to the body, because in a way, it also enhances our perception to defend our body. So I want to see if there is certain modulation of multisensory integration related to pain severity, whether those who have high pain severity may have a multisensory integration higher in the peripersonal space. So we will have different conditions, so basically only the sound alone, near and far, and then the touch-based condition alone, as well as the touch-sound interaction near the body, far from the body. And we do this while we record EEG as well, not only reaction times. As a second aim, we also want to explore the relationship not only with the pain severity, but also with the level of completeness of injury. I hypothesize that those who have higher pain severity will have a reduced boundary of the peripersonal space. The integration may happen faster, because based also on the preliminary data where I show that they have higher integration, I do believe that in the peripersonal space, they will have a higher modulation. And finally, I will be submitted another LOI to the Kremlin Foundation. And in this task, I aim to understand multisensory cognitive control mechanisms in individuals with a different level of neuropathic and pain. So I don't know if anyone is familiar with the flanked task, but basically we will present individual with a modified version of a flanked task, which is audiotactile flanked task. So in this individual wearing EEG, this is what they're looking at. They will look at the screen, they will be presented with a fixation cross, then there will be an interstimulus interval, and then there will be a target stimulus that can be either the touch or the sound, depending on the condition. So if this is the target stimulus is going to be the touch, they are going to respond whether the touch is delivered. If it's left or right, they will give a response, we will give them a feedback. So this is a condition where they respond correctly to the modulation of these two stimuli. Sometimes we will have this stimuli to interfere, meaning that they have to respond still to the touch if the touch is the target, but we don't deliver it on the same side of the auditory information, but on the opposite side. If they still say it's a right, if they still give us a response as a right, they will be mistaken, because basically the auditory information has interfered with the tactile information. So this way we are able to measure cognitive control, how they are able to suppress the distraction from auditory in order to detect the touch. We will measure EEG, and part of this group will also undergo to a home-based training on working memory. There is evidence showing that participants, they have higher pain severity, they have lower working memory ability. We want to see if we give them a working memory training for probably 2 weeks, home-based, if increasing the working memory will produce any analgesic effect. So we will have two groups depending on their end function. One group will undergo to the working memory intervention, another group will undergo just to a neutral visualization of a video clip. The working memory task, if anyone is familiar, is an NBAC, meaning that they are presented, for example, with the letters. They are asked to respond which letter is presented. So if it's a 0 back, we tell them every time you see an X, you have to press a space bar. So they're presented with the gen, the S, the X. Every time they say X, they present space bar. They press space bar. So there is not much working memory here going on because there is not. They don't have to work. They just attend to a letter. Then we have a condition that's more difficult. It's 2 back. So every time they see a letter, in this case it would be the N, would be the target. We will ask them to try us back if they saw that N. So they are presented with B, N, R, N. Then here we stop and we ask them, did you see these 2 trials back? And they have basically to be able to respond. So this is happening very fast. As you can see, it's very fast in the time. It's only 2 seconds, the whole trial. And then 3 back as well is even harder. So they are supposed to remember 3 trials back the letter that they see. So we want to study the effect of cognitive load on pain. And this is done also with the help of a consumer. So I don't know if anyone knows L'Edouard. Yeah, so I have asked him some input. He has very severe pain. And he has told me that when he watches video game, he has no pain. But if he's focused on a task, like an exam, he has more pain. So the 2 scenarios are the same. His mind is busy, but one is negative because one is impacting his ability to focus, and another one is more pleasant because he's just watching video games. So we're going to look at the effect of basically cognitive load and not cognitive load on pain interference and severity. What we can conclude. So first of all, cognitive mechanisms offer a promising new avenue for treatment, aiming to enhance quality of life and overall well-being. Combining cognitive tasks with multisensory stimulation provides a novel strategy to modulate and reduce pain perception. And finally, chronic pain is a multidimensional experience, so it's very important that effective intervention will address its sensory, motor, and cognitive components to improve outcomes. Thank you so much, and I finished in time. Any question?
Yeah. 2 questions.
Yeah, so we will do a, there is a questionnaire that we can, not, if they know they have it, but otherwise we just
So I guess my question is, how did the undiagnosed is it a secondary characteristic of autonomic dysfunction?
Yeah. So regarding the multisensory integration, the studies that we have done, we didn't control for TBI, so there we don't know. And as I said in my first slide, there is all those conditions, there is long-term effect on medication, TBI, so they will all have an effect. Autonomic function actually have an important role for multisensory integration because it has been shown that multisensory integration changes depending on the respiratory phase and on the cardiac phase. So the rest phase seems to have more integration than the phase where actually you're working out. Then probably the brain is more selective when you convex, I don't know. But that has an effect. So for the multisensory integration studies, we do not control for that. For the new study where we look more at higher function, like working memory, control, we will, screen them. We will exclude for TBI for sure. If they know they have had it, or we just do the questionnaire, and then we can correlate the score of the questionnaire. But you're right; it is hard to differentiate between all of these. That's why we need a large population. Thank you.